This video demonstrates our technique of laparoscopic sacral colpopexy and rectopexy. This elderly female has stage 4 vaginal apex prolapse, severe rectal prolapse, stress urinary incontinence, bilateral paravaginal defects, and a rectocele. The course of the right and left ureters is delineated. The rectovaginal space is entered and dissected to the perineum. The bladder has been dissected off of the vaginal apex to its base. A bowel retractor is introduced and the patient is airplaned to the left side. The peritoneum over the sacral promontory is incised to the cul-de-sac. We use sharp dissection with scissors and very little cautery. The presacral space is dissected so that the anterior longitudinal ligament is completely visualized. The posterior 60% of the rectal circumference is dissected to the pelvic floor. Further dissection reveals the course of the left common iliac vein. Mobilization of the rectum allows clear identification of the levator ani muscles. The desired point of rectal suspension is marked. A 15 by 3 centimeter polypropylene mesh is attached to the endopelvic fascia of the anterior vaginal wall and apex with number 0 braided polyester suture in 2 rows. All knots are tied loosely with extracorporeal knots. Another 15 by 3 centimeter mesh is secured to the endopelvic fascia of the posterior vaginal wall with 3 rows of number 0 braided polyester suture. The sutures at the vaginal apex join the 2 pieces of mesh. the presacral space and pelvic floor are evaluated for adequate hemostasis. The EAA sizer elevates the vagina to the desired level of suspension in the right pararectal space without tension. The mesh is attached to the anterior longitudinal ligament of the sacrum with number 0 braided polyester suture. A titanium tacker may be used as an alternative during this portion of the case. Excess mesh is trimmed. After the rectum is elevated to its appropriate location, the lateral wall of the rectum and adjacent peritoneum are sutured to the presacral portion of the mesh with braided polyester suture. The peritoneum is reapproximated over the mesh in order to decrease the risk of small bowel obstruction. This patient did well and was discharged on the first postoperative day. She had no prolapse on follow-up visits.